Hi, I'm Dr. Dan Kaufer, Associate Professor of Neurology and Director of the Memory Disorders Program at the University of North Carolina at Chapel Hill. In this video, I will go over a memory disorder assessment for cognitive impairment, including pertinent history from an informant, cognitive testing, exam and lab findings, interpretation of clinical data, and diagnosis. This case has been prepared as part of Carolina Memory CareNet, a joint project of East Carolina University and the University of North Carolina at Chapel Hill. The patient is a 76-year-old woman whose son reports a 2-year history of cognitive decline. He reports that her main problem is with short-term memory, such as repeating herself and getting lost in familiar areas. She also stopped driving due to anxiety a few months ago, and about a year ago he took over managing her finances. Her medical history includes hypertension and hyperlipidemia. She takes a statin drug and a baby aspirin as well as an antihypertensive agent. She's a retired teacher, widowed, with no history of tobacco or alcohol use. Her score on the mini mental state exam is 21 out of 30. She has poor time orientation, poor constructional praxis, and poor recall, 0 out of 3. Now, one way to get more information is to give the patient either a category clue, such as fruit, or 3 choices in order to help them remember the word. To review, a retrieval problem is helped by a category clue or multiple choice, whereas a storage problem is not. In her case, with multiple choice recall, she still was not able to identify any of the 3 words. So, is this a storage or a retrieval problem? Of course, this is a storage problem. Even with multiple choice, she's not able to retrieve the words that she was able to repeat back initially to prove that she heard the words in the first place. Here are the results of fluency testing. In 1 minute each, she generates 4 animals representing category fluency and 8 F words reflecting letter fluency. In contrast to a typical profile where category and letter fluency are about a 2-to-1 ratio, I use 18 to 12 as a rough guide. Her category fluency is very poor. Next, we look at her clock drawing, a square with a 12 at the top. That's a really bad clock. So she has significant problems both with visual spatial, the clock face, and executive components of cognition. That represents setting the clock hands. Her physical and neurological examinations are uninformative, and screening laboratory tests are all within normal limits. At this point, what are you thinking? This is a classic presentation of Alzheimer's disease. Here's her MRI brain scan. Hippocampal atrophy is evident on the left picture within the red circles. There's also generalized cortical atrophy as well. Although hippocampal atrophy may help distinguish Alzheimer's disease from other disorders, it is not a clinically reliable tool to use in clinical practice. Now on the right side, you see some white matter signal hyperintensities in the periventricular and subcortical white matter. For this, an MRI report would typically say generalized cortical atrophy with a mild to moderate degree of periventricular and subcortical signal hyperintensity. And the question here is what to make of the white matter hyperintensity. Does this factor into the diagnosis? Does this explain her clinical presentation? Well, it's impossible to say, but if it is, it's probably a minor component. Many cognitively normal older persons have white matter changes like these, and her history, neurologic exam, and cognitive testing all point to Alzheimer's disease. Deep white matter cerebrovascular disease does not explain her storage memory deficit and her worst performance on category versus letter fluency testing. So based on these 2 parameters, which are often but not always clinically useful for distinguishing Alzheimer's from other disorders, the deep white matter changes are most likely incidental. Therefore, the diagnosis is probable Alzheimer's disease with a secondary component of cerebrovascular disease. This concludes the case presentation. Thanks for watching.